Dear friends from Polio and Deformity Correction Center, I will like to share my experiences regarding 3D CT scan in limb alignment in deformity. Dear friends, I also want to emphasize that improper full length x rays of the limb can give rise to wrong information, which can lead on to wrong execution. And what is the role of 3D CT scan in evaluation of the limb alignment? We all know a general orthopedic surgeon mostly does not try deformity correction because they don't have access to the true full-length lower limb X-rays. The purpose of this presentation is to provide all the orthopedic surgeons a cheap, precise, easily available alternative, which can also give rise to more information regarding soft tissues, true shapes of the joints, bones, which we are going to deal with, and true nature of the deformities in frontal, sagittal, and rotational planes. To start with, I will like to tell that since last 5 years, I have used this technique of 3D CT scan in 107 cases. The CT scans they were used in single level deformities as well as multiple malalignment, malorientation, malrotational syndromes. How would you like to see the earth? Just flat like this earth, or a three-dimensional object like this? How long you will keep on seeing deformities just like this, plain only one or at the least two dimensions, or you want to shift to a newer method, 3D CT scan images for alignment. Dear friends, as the subject is slightly complex, let us start with a girl who is 24-year female is having genu varum right. She had brought her own frontal pain scanogram from an institution in a metropolitan city. Let us calculate the deformity, its level and magnitude. Basic map the ABC. Map means measurement. M stands for measurement of the mechanical axis. Deviation, MAD. A for analyzing the joint angle and P for picking up the deformed bone. First M, measure the mechanical axis deviation, MAD. If center of the hip and center of the ankle are joined with a line, the knee stands out of this plane. This means there is malalignment and the knee is in varus. Map the ABC. First M means measure the mechanical axis. In this, once we have measured, we have found that the knee is in varus. Then we analyze the angles. And on analyzing the angles, we find that upper end of the femur, MLPFA, is normal. Lower end of the femur is MLDFA is 96 degree, varus. MPTA is also varus because it is minus 81. And lower end of the tibia on the right side LDTA is minus is 112, which means varus. So map first M then A, analyzing the angles, and we have found that it is the lower end of the femur which is in varus, upper end of the tibia and lower end of the tibia they are in varus. Then P, map P of the map. P means pick up the deformed bone, because the angles they were abnormal. At the lower end of the femur there is varus, at the upper end of the tibia there is varus, and at the lower end of the tibia also there is varus. Then we come to the ABC, map the ABC. First is A. Where is the apex or the location? And what is the magnitude? The deformity is at the lower end of the femur. It is 10 degree in magnitude, 10 degree varus. It is just a articular deformity. Upper end of the tibia, again 10 degree varus. It is just a articular deformity. We are on the map ABC A. ABC A. Where is the apex? The apex of the deformity in the lower end of the tibia is at the level of the joint, and it is 22 degree varus. So dear friends, this means there are 3 levels where the bone is getting deformed: the lower end of the femur, upper end of the tibia, lower end of the tibia, which means 3 osteotomies they are to be performed. Okay, these calculations they were on the scanogram which the patient had brought, and we have calculated. We will do 3 osteotomies and resolve the deformity. Let's go to the first step and review. And we find that the patella is not centered. The patella is not centered, it is slightly off center. I think it doesn't matter. But let us calculate. Does it matter or it doesn't matter? This is where lies the purpose of this whole exercise, whole presentation. I did my own frontal plane scanograms, and what I did in that I placed the patella center in the AP view. I placed a marker of 2.5 centimeter, and I raised lower limb on the blocks by 2 centimeter so that the pelvis is secure. So first we had a scanogram from the patient where the patella was not marked, marker was not there, and the limb was not raised on the blocks. Now I have corrected that and I have done my own scanogram. Let us calculate, is there any difference of slight off-center patella? Another advantage is that I can get the DICOM images from this, and on Horror software we can accurately and precisely draw the drawings. What happened? Dear friends, to my surprise, now the MLDFA is 89 degree. It is normal. And upper end of the tibia MPTA is 76 degree. and lower end of the tibia LDTA is 160, which means that lower end of the femur is normal. The deformity is at the upper end of the tibia and lower end of the tibia. And to confirm that, we did a 3D CT scan and we found here also that neck shaft angle was 131, which was normal. MLDFA was 90 degree, which was normal. MPTA was disturbed, and there was proximal angular deformity of the tibia by 17 degree, and also a deformity was present in the lower end of the tibia. Now we are more precise by doing 3D CT scan, and to my surprise, we reduced one osteotomy, which means instead of 3 osteotomies to correct the deformity, now we will do only 2 osteotomies, that too only single bone, tibia upper end and lower end, and we have omitted the lower end of the femur. So this concludes, if the patient can bring his own scanograms where it is improper, you should not rely on it for your final calibrations. You have to do a proper your own scanograms and also a 3D CT scan. Why? Number one, why 3D CT scan should be done in deformity corrections of the lower limb? First is that most of the orthopedic surgeons, they do not have any access to the true frontal and sagittal plane images, full length x-rays of the lower limb. But 3D CT scans, they are everywhere in each and every city. And the second advantage of 3D CT scan, it gives you exact midline patella. What is the third? It gives you exact sagittal plane images of both the sides. It gives you frontal plane and sagittal plane, both the sides, full images. And dear friends, the fourth advantage is it gives you rotational parameters. How much is the anteversion or retroversion of the femur, and how much is external rotation or internal rotation of the femur. This information cannot be taken or observed with the help of full-length scanograms. The fifth advantage is you can plan exactly where is the first cora, what is the second cora or the third cora, what should be the length of Ilizarov apparatus, the level of osteotomy from the knee or the ankle joints. The sixth advantage is it is cheap. It is giving you both sides frontal plane, both sides sagittal plane, rotational issues along with many other things. It and my city, this costs only 2,200 rupees. These 3D CT scan can be used to get 3D models made so that you can exactly look the type of deformities and have a better understanding of the bones and deformities and the joints you are going to deal with. The eighth advantage is you can really see the bones, really see the joints which you are going to deal with. You can peep into these joints. And dear friends, the ninth advantage is you can really see the relationship of the bones and joint with nearby neurovascular structures, and you can plan the entry of your shank pins and wires where from they should enter. You can plan the path of their osteotomies. These are nine major advantages along with many other. And so the prerequisite is positioning of the patient. The knee should be in full extension. Keep some weight on the front of the knee so that it is in the front of the knee. On the front of the knee so that knee is in full extension. The ankle should be in complete dorsiflexion. With the help of a crepe bandage, you can do this. And you can crop the images. For sagittal plane as well as frontal plane, like this. And then you can crop the side which you want to see. Left side or right side or both the sides. Dear friend, for cropping frontal plane images, this is how patella is centered and full length AP images can be procured. Similarly, for sagittal plane, like this, the condyles on the lateral view, once they overlap each other, those images are for the sagittal plane. You can procure them for both the sides. And believe me, such kind of sagittal plane images in a normal scanogram, even after my scanograms experience with 3 big cassettes, such clarity is not there even after about 14 years of using them. One thing. Second thing, that it's very difficult to get lateral condyles overlapping on one another in plain scanograms and see the upper end of the femur. Foot and ankle reference lines and angles pertaining to the alignment, they can also be studied in detail. In vascularized lower limb non-union of the tibia, the placement of the shank pin to avoid any injury to the vessels can be thoroughly studied and then executed. And dear friends, you can really know the kind of joints you are going to deal with, which is very difficult in plain scanogram. Sorry. You can also see three-dimensional shape of the bone you are going to deal with, like this. Femur is almost flat femur. In the end, I will like to say that 3D CT scan gives true nature of the deformities in frontal, sagittal and rotational planes. It is cheap, precise and easily available. The soft tissue information is there along with true shapes of the bones, joints and many other advantages. We must shift now from two-dimensional to three-dimensional precise images for calculation of various angles. This is the same girl which we started before and after 7 months, and these are the angular parameters of various correction after the osteotomy has healed up. And dear friend, in complex deformities which are at multiple levels, multiple joints, with all the planes involved, frontal, sagittal and rotational. This is a boom. This can be used 3D CT scan in single, double level or multiple level deformities in a single plane or multiple level plane. Thanks a lot for kind attention, and my humble invitation to all the respected orthopedic surgeons to please visit whenever possible with prior information, and if you have any doubt you can ask by emailing